Good afternoon. I'm Dr. Anthony Levinson, a psychiatrist here at McMaster University, with my colleague, Dr. Richard Sztramko, geriatrician, also here at McMaster and Hamilton Health Sciences. And welcome to our 8th live event as part of our iGeriCare.ca series of live Q&A events. Today's topic is on delirium and confusion in the hospital, discussion of what delirium is, how it can impact a person with dementia, how to recognize some of the signs and symptoms of delirium or acute confusion, and also what you as the family caregiver can do to help. Things you can do to hopefully prevent it or at least address it if your loved one is in the hospital. So welcome. A reminder that you can use the Facebook commenting tool to send any questions or stories or comments. There is always a survey where you can give us feedback on the live event and also suggest future live events. And you can, if you're watching on our iGeriCare.ca/events page, you can also submit comments that way. So we look forward to any questions or comments. But let's get started a little bit just to give a brief overview of what is delirium exactly.
Mm-hmm. So we've discussed dementia quite a lot over all of the different lessons, and have talked about a slow, steady decline in short-term memory or potentially executive function and visual and spatial skills. So we've addressed all of those things, but the key factor being that it's slower and gradual in nature. Delirium is an acute confusional state where people have an abrupt change in their cognitive capacity. They may display inattention, they may appear confused, have disorganized behavior, and often it will fluctuate throughout the day. So instead of having an ever-present state of cognitive impairment, you may see them in the morning and they look quite all right, and then you'll come back and see them in the afternoon and they may be quite confused and disoriented. There are additional things that will happen in a delirious state as well. So people may actually see things or have visual hallucinations. Occasionally, something called illusions, where they'll see something on the wall coming out of a shadow or patterns. People may feel paranoid or experience delusions, which we've discussed before. So, feelings like someone's trying to get them or steal something from them, or generally feeling unsafe while in hospital. And there can also be emotional disturbances as well. So, people may feel quite down or quite anxious. But the hallmark being it's an acute confusional state. Usually, a delirium will come on in the presence of another medical condition or insult to the brain. So, for instance, if somebody has a urinary tract infection, that may cause a lot of inflammation throughout their system, and it may cause them to be confused or in a delirious state. Or some people may be on too many medications. They've just started a new medication, and that can kick off their delirium or their acute confusional state.
I think one of the things that we talked about in our lessons was the importance of investigating and ruling out delirium or another medical cause when somebody is presenting with some of the signs and symptoms of dementia. But I guess one of the important things for us to highlight here today is a person with dementia is at much higher risk of developing delirium if they develop some kind of intercurrent infection, as you mentioned, urinary tract infections or pneumonia. These are things that we commonly see in the hospital. So your loved one may have some, even an early stages of dementia or mild cognitive impairment, but an infection or multiple medications, or another example that we see often is somebody who comes in for a surgery and a day or two after the surgery they are very much not like themselves. So these would all be common scenarios that are seen in the hospital, and it's important to realize that the person with dementia is at higher risk of developing delirium. I guess, how common is it? I mean, I guess you and I seem to see a lot of people in the hospital with delirium.
Absolutely. We were discussing this a bit earlier before we came on, and there are a lot of different numbers. I think the big take-home message, though, is that it's very common, anywhere between 20 and 50%, depending on whether you're in an intensive care unit and require ventilation, or whether you're on a post-operative ward, or you're just in for a short stay for a medical condition. Your risk will change depending on a lot of different factors, but it's very common and it's very important. One of the big things that we talk about and why we want to talk about this is delirium is associated with a lot of poorer outcomes. So for instance, if you have a delirious episode when you're in hospital, you'll be more likely to be lying around and become deconditioned, and you will have a higher risk of having rehabilitation services afterwards or going to a long-term care facility. It's also associated with an increased risk of mortality.
Mhm.
So it's a really serious condition, and can also be associated with more persistent cognitive dysfunction for longer periods of time.
I think one of the things that is also important, though, is that if somebody's may have a dementia, but if it seems like their dementia symptoms are all of a sudden getting worse a lot faster,
Yeah.
so that they're much more confused, whereas 2 days earlier they were sort of more or less their usual self, or what we sometimes call at their baseline level. If all of a sudden their memory's worse, their language is worse, and it seems to have changed radically in a day or two, it's very important for the caregiver to consider getting that medical assessment to make sure that there isn't something that sort of tipped the person into delirium.
Yeah, I think that's a key message. And then one of the biggest features that may change in the cognitively impaired person, where they have this stable difficulties with remembering things, let's say, is the inattention that happens when somebody is delirious. So not being able to follow a conversation as well, not being able to follow commands, being disorganized in how they're going about their day-to-day activities. The abrupt change, I think, is the key, but there's also a change in what their cognitive deficits look like.
What I would say is it can also be something that is very, very frightening for family members. So, we sometimes talk about, there are some people who get delirium and they're sort of quietly delirious. We sometimes call that hypoactive, because they are not necessarily voicing hallucinations or delusions or anger. And then there are other people who develop a very hyperactive or agitated delirium, and that can be exceptionally frightening for families, where the person, even if they have a cognitive deficits and a dementia, all of a sudden they aren't necessarily recognizing the family members, or they're angry and agitated. They may be shouting at staff, or accusing people in the hospital of trying to harm them or poison them. So those cases of delirium can be very frightening for family members, who may see this abrupt change and not really know how to handle that. They may feel very uncomfortable with some of those symptoms of delusions and hallucinations that can happen during a delirium. So we'll come back and talk a bit more about some of them, but we've got some good questions coming in. So we have a question from Montreal. Is delirium ever permanent? And I guess this might be a good chance to address a bit of a comparison of some of the features of delirium and dementia, and then we can ask specifically about that. So we've talked a bit about some of these issues already. In delirium, the change in symptoms seems to come on quickly, sometimes in a matter of hours or days. So we use the term acute or subacute, whereas most of the dementias are more slowly progressive or degenerative, that gradually there's been a disturbance in thinking, and the signs and symptoms are more stable, even if they may be gradually declining. Whereas in the delirium, things kind of come on very, very suddenly, typically. And then with delirium, you do see some worsening memory and thinking, but signs can change from one moment to the next. And I think that's one of the things that's really confusing sometimes for family members. You may have one family member who goes in to see their loved one in the morning, and so they seem really good. They seem to be recovering. They seem to be getting better. And then a different family member goes in the afternoon and says, well, they didn't even recognize me. They were, picking at things and looking all over. And so that fluctuation or change in the status is one of the things that is really a hallmark of delirium. And I think this happens with our clinical assessments too. You go in and see somebody at one moment and they seem great, and then the next day it's sort of one step forward, two steps back sometimes, because the picture can be changing. Whereas, dementia, it's really, you wouldn't expect to see changes that rapidly, that it's more or less stable over months and sometimes even years, even if there are some declines. So one of the other things, back to the question from Montreal, typically delirium is not permanent, it's reversible, and we do think of dementia as more permanent changes. So whether if we wanted to get into the nitty-gritty, we could think of examples where somebody might have an insult to the brain, like a stroke, that triggers a rapid change and a delirium type of thing. And then the deficits are more permanent from the stroke. But in the general way, the examples that we've talked about, where there's an infection and the infection is treated, and the person may gradually recover. I guess, can we say a little bit about that recovery or reversibility in terms of if somebody has an infection and it's treated, like a pneumonia or a urinary tract infection?
Yeah, and I think it's a really important thing to bring up, in that people get really excited about permanent cognitive dysfunction related to strokes, but there are instances, because delirium is so poorly understood, like we don't know exactly what causes it. It's some combination of stress and inflammation and changes in the chemical levels in your brain. The honest answer is we don't really know what causes it. And so there's a general insult to the brain when you get a delirium. And there are people who, even if they haven't had a stroke or don't have a persistent insult to their brain, can still have persistent cognitive problems out to 6 months. Now, the recovery issue that you talked about, the major fluctuations that they experience, or the aggravated behaviors, or the really severe confusion, will get better after that initial insult gets better and gets treated and removed. However, people can still have cognitive slowing and problems on testing for a long time afterwards. And it may take months to get better after you've had a delirious episode.
And I would say that sometimes in the hospital setting, healthcare providers, might actually be a bit impatient with recovery. So, even if you recognize sort of the cause of the delirium as an infection or an adverse effect of, too many medications, especially if somebody does have underlying dementia, the recovery is not necessarily like, boom, you've treated the infection and a day later they're better. So people can take time to recover from delirium, and people with dementia take longer to recover than somebody who doesn't have cognitive symptoms before the delirium. But we're a bit impatient in the hospital setting, and I think sometimes families are understandably wanting to see their loved one get better as well. What's frustrating, I think, sometimes, if somebody isn't getting better as fast as we would like them to, then they may get labeled as it being permanent. But as you say, sometimes it can take longer to recover, maybe weeks or longer, even though in many cases people are substantially better within a couple of days of treatment of an infection. In other cases, it can last much longer, and it's important to be patient and not necessarily label somebody as in a new permanent state. Let's take another question from Tusket. Is there any medication specifically that works best for a person with alcohol-induced dementia who is very volatile?
I think we've covered this in different lessons before too, in terms of the different ways that alcohol can impact the brain. One of the first things we always look at is to see if there's the possibility that they have Wernicke's encephalopathy, which is related to thiamine deficiency and can be treated. So we always try that. And then there can be persistent damage to the brain that just related to the alcohol itself, and then impacts on the liver as well in terms of causing damage to the liver. And so the first step related to the alcohol-induced cognitive impairment is to find out where in that paradigm somebody exists. And then there's no one medication for emotional volatility. We always talk about documenting very specifically what the volatility looks like, what the behaviors look like, whether there's any antecedent things that may be causing the behaviors. We call them responsive behaviors. And so I think there's not one approach, but trying to do non-medicinal or medication approaches first is always our go-to. And then there's a whole host of medications that could be tried. But we don't try not to get into too much specific advice.
I guess just to reiterate, when somebody has acute confusion or delirium and has a history of alcohol-induced dementia, one, you want to make sure that they're not acutely intoxicated. Two, you want to make sure that they don't have that Wernicke's thiamine or vitamin deficiency, because that can lead to permanent, even worse memory impairments. And Wernicke's, sometimes people have those odd eye movements and unsteadiness and delirium, which is very common and can be managed with drugs like Valium in the benzodiazepine category. But to your question about once somebody has a diagnosis of alcohol-induced dementia, there's no great evidence to support a specific medication. Many things do get tried. A lot of times people will try sort of mood stabilizer drugs because of that volatility. So it's a good idea if the volatility is not manageable and non-medication things have all been tried to maybe talk with that person's doctor about a trial of some other classes of drugs. But unfortunately, there's not great science for that type. Question from Toronto. When a person is hospitalized because of delirium, will it ever go away if they remain in the hospital?
Yeah, absolutely. It is acute confusional state, but if the underlying condition that causes it is treated, it can definitely go away. Even if they're a little bit more frail and they're going to be staying in hospital for a long period of time or going to a long-term care facility afterwards, you can still get complete reversible of the delirious state in some cases.
What is probably really important to identify is delirium is definitely not just one thing. So a bit like dementia, it's an umbrella term for this sudden onset of a state of confusion that fluctuates or changes. And so probably the single most important element of delirium, in addition to making sure that the person is safe, is to find the underlying cause, identify it, and hopefully, treat it. So expect that if you bring your loved one to hospital or they're in hospital and develop a delirium, that should trigger investigations to see if you can find the underlying cause. So often the healthcare team will ask for a urine sample to maybe do a chest x-ray to look for a pneumonia or an infection in the chest. They will do a complete blood count or a CBC looking to see if there's any other sign of infection or low red blood cell count like anemia that might suggest there's blood loss. They may or may not take some kind of brain imaging, like a CT of the head, to see if there's something else that's been missed. A lot of times, medications are the culprit, so that you would want them to take a full look at the list of medicines. And we talked about some of the medicines and adverse effects of medicines before in one of our earlier live events. But there are certain medicines like pain medicines or sedatives, like might be used for sleep, that can potentially trigger confusion. So
I think the other great thing So getting into the assessment, and it could be it's quite a complicated and long differential diagnosis. So there's first pass investigations and second pass investigations, but I won't get too much into that. The reason I like delirium in one sense is that the family can get involved and caregivers can get involved. It's not a completely medical thing where, well, if you have a broken leg, then only an orthopedic surgeon can do something about that. But I think delirium is really a team related disease. And so there are evidence-based non-medication interventions that can help. And they help quite a lot when you look at the evidence. The size of the impact that they have is great with respect to trying to prevent delirium. And so some of these things include helping to regulate sleep. So trying to, if possible, on a busy medical ward, making sure that the patient has earplugs or that they can turn all of the lights out so that it's better for them to get sleep. Reorienting them on a frequent basis, so letting people know what date it is, what time of day it is, why they're in the hospital, who's around them, what their nurses' names are, what tests or investigations they have to get done that day. Getting people up and walking around, especially if they've undergone surgery or they've been weak and not moving for a few days. It's amazing to see what the brain starts doing when physically people become active again. I
think it helps to differentiate sort of the daytime and the nighttime too, because if you're just in bed the whole time, it's just one long, blend of day and night.
Yeah, so. You'll walk in and you'll see people as well, and they won't be eating and drinking properly. When they're acutely confused, somebody may leave their tray just out of reach, so they become dehydrated or malnourished because they're not getting appropriate access to food and water.
Or if they are confused and can't protect and swallow cleanly, they may need assistance eating so that they don't, choke on their food while confused.
And then other things that the medical practitioners might try and do as well is try and remove anything that restrains the patient or makes them feel like they're tied down. So trying to get rid of any physical restraints if they're in use, trying to remove any Foley catheters or intravenous lines so that the patient feels a little bit more comfortable and they don't feel tied down and they won't confuse those restraints for something else that might be more scary to them.
I like your point, though, about, because delirium changes moment to moment or throughout the day, family caregivers and friends can be eyes and ears to let the healthcare team know about changes in sensorium. Is the person, do they seem to be talking about things that aren't there? Do they seem, confused at times? Are they making sense? Because the healthcare team may go and visit once in a day and see them at their best, but the family members can sort of say, this is not my loved one. They're not making sense, or they really seem confused this afternoon. So this ties in well with another really great question. Are there specialized, standardized tests for non-psychiatric clinicians to assess and detect delirium and confusion symptoms?
Yeah, absolutely. So there are several, but the one we focus on predominantly is the confusion assessment method. And it has there's a long form which takes 10 to 15 minutes and a shorter one that takes around 5 minutes. And it has very specific questions on whether the delirium is acute and fluctuant, whether there's a component of inattention, whether there's a disturbance in consciousness, or whether they're displaying disorganized thought. So there's specific questions that the healthcare practitioner can go through. You don't need to be a physician or a psychiatrist to do it. And they'll give you a score based on whether you have a combination of the first two items and then either the third or the fourth. And so the sensitivity, so the ability to detect delirium based on that test is quite high. It's over 90%. So in particular, when people don't have physicians on the ward, but they want a standardized way of finding whether somebody's delirious, then they can do that. The limitation, though, as we talked about, is there's fluctuations. So if you're testing them at a good point in the day, then you may not pick up all of the delirious episodes on the ward that you're looking for. And then sometimes the other downside to it is if you give nurses too many tests to do on a regular basis, they don't take as much time to do it. So I think it's important to focus on people that are high risk instead of just documenting, CAM is negative, CAM is negative. It's focusing in on, let's say, an older patient that's in a post-operative state that has known cognitive impairment. You'd want to make sure you get the confusion assessment method done on them.
And I think there is a confusion assessment method, or CAM variant, for informal family caregivers.
Yeah.
I think they've trialed that at a few hospitals. It's not in widespread use where we work, but actually the actual CAM, I would say, is employed regularly now by staff, and certain environments where people are at very high risk of delirium, like the ICU, the intensive care unit, they would regularly do that as part of the standard practice. So if you were a family member, you might ask, "Oh, do you know if a CAM was done? I'm worried that my loved one has confusion." So otherwise, I think the clinical assessment, even if they're not using a standardized tool like the CAM, should be asking people about, whether there's change or some of the other symptoms that we've talked about.
There's some kind of practical, less scientifically based tests as well, just to test for inattention. So one is a digit span. And these are things that you might be able to do at the bedside. So just saying like 6 digits forward in an easy normal cadence, or 4 digit backwards, or something really simple is just getting somebody to say the days of the week backwards or the months of the year backwards. And if you know that they were totally fine before, didn't have any troubles with it, and now they're having problems and stumbling over their words or not being able to get through even simple tasks like that, then you have some sort of clue that they need a little bit more attention and assessment.
As a general rule, we don't kind of recommend to the family caregivers that you get into sort of quizzing your loved one, but take a more supportive stance and help to orient them, make them active. But if you are at the bedside, maybe when somebody's assessing that, and you can say, "Oh, a week ago, he absolutely would have been totally oriented."
I think the tough thing too that we experience is not all units, wards, or hospitals, or physicians for that matter, are as familiar with delirium, and so definitely leave the tough stuff to the professionals. But if you're in a situation where the professionals don't have as much understanding of it, then you may need to advocate for your loved one.
And we'll come back to that maybe and talk a bit about some of the psychiatric symptoms that lead to me getting involved. Like, I think sometimes there are people that, as you say, they don't recognize that the person has delirium. So we'll come back to that in a sec. So can you discuss delirium after surgery in the elderly? What's the latest research on the relationship between cannabidiol oil and delirium, or CBD oil and delirium?
Sure. So age is actually a risk factor for delirium after surgery in the elderly, and all the things that go along with age. So multiple medical conditions, if you have high blood pressure and diabetes and chronic kidney disease and heart failure, then you're putting yourself at higher risk. Older people tend to be on more medications as well, and so there's greater risks of having interactions between those medications. Older people are also more sensitive to the effects of new medications. So often after a surgery, people will require pain medications, or sometimes on the ward, if they're not sleeping, they'll receive medications that are unhealthy, like a benzodiazepine, Ativan, let's say, to try and help them sleep. But they'll be more sensitive to that, or they'll be more sensitive to the pain medications.
Or even the anesthetic agents that they've received during the surgery. So if it's a longer surgery and they've had more exposure to the anesthetic to keep them under during the procedure.
We talked about the importance of mobility. There are oftentimes people that will come in a weaker, frail state, so it takes them longer to get up and moving after surgery. So that puts them at greater risk as well to do that. And we've talked about the cognitive impairment that people will have before they come in. So age is the greatest risk factor for cognitive impairment. About 8% of people above the age of 65 will have a dementia, and 20% of people will have some form of cognitive impairment, either MCI or dementia. So I think that those are the biggest things that can help. But all of the preventative things are especially important in people that are older and going into hospital.
I think you mentioned as well, when people go in for surgery, they often have other lines or tubes as part of the procedure. So they may have an intravenous that's put in that stays in terms of being able to deliver medicines, and that intravenous could be a site for infection. They will have a catheter to help get urine out of the bladder, and if the catheter stays in, it can be a source of infection, and those things can also contribute sometimes to delirium for people who have had a surgery. So, the cannabidiol oil and delirium.
It's not. I mean, we talked about this in other episodes. Using cannabidiol as a third-line treatment, maybe for neuropathic pain, but I have not seen any high-quality studies on using cannabidiol and inducing a delirious state. I mean, I guess
I've had some, not related to post-op, but I have anecdotally had a couple of cases now where people were using CBD oil, for pain relief, and became delirious because they were using high volumes. So I guess, I would be cautious about the use of cannabis and cannabis-related products in the setting of dementia or delirium. And if somebody is using CBD oil regularly and becomes delirious, it might be worthwhile to hold use of it until the delirium clears. But I'm not aware of any other research on it. Can there be visual hallucinations with delirium? We're going to give that 2 thumbs up. Absolutely.
Definitely.
In fact, visual hallucinations are probably some of the more common ones. And in our live event where we talked about particular medications and the risk of delirium, I think we talked about the anticholinergic delirium. That's one that's often associated with visual hallucinations. Seeing bugs seems to be a common one, and you may notice your family member picking at things. They may disclose, "Oh, do you see those animals or children or whatever?" But they may also be picking at things, and you might ask them, "Oh, what are you picking at there?" So for sure, visual hallucinations are relatively common in delirium and can be disturbing. I would say in most cases, people seem to have kind of upsetting delusions and hallucinations when they're delirious, but not always the case. Sometimes they're a bit more neutral, like dogs or cats or pets kind of thing. Question from Kitchener. Does delirium always resolve completely, and does it increase the risk for developing dementia?
Sure. So we addressed a little bit about the resolution side of things. So usually that acute phase will always resolve completely with treatment of the offending or underlying insult. There are some people that I think discussed that it may take them 30 months to get over that acute stage, and then they'll settle out into like a more chronic phase where they might not get back to where they were previously. And so in that sense, it does increase your risk of developing a dementia, which is permanent cognitive dysfunction that impairs your ability to function independently as an adult. So
I'd say most of those cases, though, there was probably dementia before the delirium, and it was just not as obvious because maybe somebody was functioning reasonably well at home or they had supports, and the delirium sometimes unmasks that there were more cognitive deficits there.
I think it's important to note too that not all deliriums are created equal. There are severe, profound deliriums that take a long time to resolve, and there are very quick, short ones. And it's kind of more like the weaker you are as a person generally with your medical issues and your brain health, the less of an insult it takes. For some people that are very cognitively impaired, all it does is take them changing their environment. So they weren't even necessarily that sick, but you put them in a different environment and they become confused, whereas a young, healthy person that has a severe pneumonia might not get delirious at all.
The other question is an interesting one. Does it increase the risk for developing dementia? And I think what we can say is it's not necessarily a causal link where, if you get episodes of delirium, you're more likely to develop dementia. But what we could say is there's an association there that people who have a diagnosis of dementia already are definitely at increased risk of delirium. And also, I think if you take all comers, I have a vague recollection of this stat. If you take, all people over the age of 65 who don't have a diagnosis of dementia yet, but who develop an episode of delirium, their 5-year risk of being diagnosed eventually within that 5 years with dementia is very high.
Right.
Sort of 25 to 50% of those people will go on to receive a diagnosis. But again, probably not a cause effect. It's probably not the delirium causing the dementia. It's probably that there was some underlying cognitive vulnerability that predisposed them to the delirium. So if hydromorphone triggered the delirium, would you avoid using it ever again?
I think it just depends on the dose, really. So there are some people, if you're a frail, older, 90-year-old, female that received 2 milligrams, which is a high initial dose for hydromorphone, and it caused you to be confused. It might not be the hydromorphone. It might just be that the dose was a lot higher. So, I mean, if at all possible, you'd avoid hydromorphone because it can induce a delirium. But if you needed it, just using it at a smaller dose. It would be important in that situation, though, to really dig deep into the history, if you can, to find out what were all of the circumstances around the hydromorphone. So people will often say, oh, they received hydromorphone and that caused a delirium, but they were also in the post-operative state where they received Gravol or they received a benzodiazepine,
a urinary tract infection,
or
at the
a wound
same
infection,
time,
or a post-operative pneumonia. So
it's very important with any medicines, but probably specifically with drugs like hydromorphone, which are a very potent opioid or narcotic, to really be assessing the risks and the benefits. Certainly in the last few years, the pendulum has swung towards a greater appreciation of the adverse effects and the risks of the use of opioids. But again, there are going to be some contexts with intractable pain, which can also cause confusion and obviously, physically be very difficult to take. So I don't think we'd just sort of say no hydromorphone ever, but I guess it would probably be worth identifying to the care provider that, when my loved one received this medicine before, if you can figure out what dose they had it or whatever, even better, but just letting somebody know that they did have confusion when on that medicine before, and that can maybe be factored into the risks and benefits of it.
And anecdotally, I've resolved delirious episodes just by decreasing the dose of hydromorphone. That's too high for you. Let's just turn it down. The next day you come back and everything's totally fine. So,
medication combinations, I feel, are that way. So sometimes when we see patients, and I was going to say I'll sometimes get referred to see somebody. Maybe they're 75 years old and they haven't ever had a history of psychiatric symptoms like hallucinations or delusions. My initial reaction when I'm asked to see somebody like that who's never had those kinds of issues before is they are probably suffering from delirium and having these symptoms of hallucinations and delusions. And often the culprit is medication adverse reactions, drugs like opioids, but it's the tremendous numbers of medicines sometimes. We call it polypharmacy, because often, you'll have an entire page of orders just of 15, 20 medications, and each one on their own might not be a culprit, but the accumulation of them, especially ones in the opioid family, and you mentioned sleeping pills or pain meds, just the accumulation of all these medicines on a vulnerable brain. So recognizing that and then either reducing the doses or taking it as an opportunity with the pharmacist to sort of say, hey, can we work together here to de-prescribe any of these agents that aren't necessary? And so it's an opportunity, if somebody does have an episode of confusion, to kind of take a fresh look and see if there's a more rational approach to the medications. So.
I did want to touch on one additional thing about the lack of resolution of delirium. And we talked about, what happens 98% of the time and then what happens in some rarer instances. And if somebody is having persistent hallucinations and persistent fluctuations in their level of consciousness and the cognitive problems are still there and it's not resolving after this initial delirious episode, those are some of the core features of dementia with Lewy bodies. So I think, if things are persisting for long periods of time, you've had a healthcare professional look into everything and see there's no reversible causes, and there's still these persistent hallucinations, fluctuations, and cognitive impairment, then you need to be concerned about dementia with Lewy bodies.
Oh, that's a good point. I would say a bit of a masquerader in that sense. Often, especially in the hospital setting, it will be, we don't understand why this person's delirious or still delirious, and then on more careful look and observation over a longer period of time, the diagnosis of Lewy body dementia sort of think, okay, yeah, this person has some of these other features that are consistent with that. So why don't we've got a few minutes left, and maybe we'll just talk a little bit about one of the other tips. I want to go back over just quickly. Again, you're the caregiver, you're at the bedside. Mm-hmm. What are some of our suggestions for what people can do to help? So maybe we'll just do a quick recap of things that caregivers can do to help. You mentioned, being supportive and sort of helping to reorient people, remind them, you're here, you've been in the hospital for this many days. This is, what's going on now, reminding them of the date and where they are. And what are some of the other tips that we would recommend?
In that sense, so speaking slowly, calmly, using a reassuring tone of voice, making sure that your phone number is actually available at the clerk's desk. There are some times where people will be wildly delirious at night, 11 or 12 o'clock, and all we have to do is get a family member on the phone to talk to them and be more reassuring to them too. So all of those things, redirecting people gently. So if they're getting very agitated and frustrated about things, try not arguing about them directly about what's happening and saying you can't do this, or being physically intimidating to them, but being gentle and trying to redirect them, offering to get them a cup of tea or perhaps a glass of milk or a snack, and come with me, we'll go and get you a snack, or is there a special show you want to watch, or do you want to talk to one of your family members?
Trying to reduce distractions too, so that when you are with the person, if they have a TV or there's other things going on, try to turn off the TV channel, look at them, speak calmly, and try to eliminate other distractions, because people their attention really fluctuates during delirium. They'll often be reacting to noises or sounds elsewhere. So the more you can try and eliminate some of those distractions in the environment, and as we said, try to offer some stimulation, things that are familiar to them. So there's no real one magic thing, but doing a number of those suggestions can be helpful.
One thing I forgot to mention actually were the glasses and the hearing. So sensory deprivation can invoke delirium as well. If you're in a room and you become disoriented, or you don't know where you are, you're slightly confused and you can't see what's happening around you, it's very easy to misinterpret shadows or lights. And if you can't hear what people are saying, then you won't be able to receive the reorientation that they're giving you. Hearing aids become a big problem because they're so expensive. Oftentimes the prescription for the hearing aid is out of date. They become lost in hospital.
Dead batteries.
So you can always ask for a pocket talker, which basically looks like an old Walkman where you put headphones on and there's a microphone attached to it. And I never have had any problem speaking with anybody, irrespective of how severe their hearing problems are.
Okay.
So making sure they have their glasses on, obviously, or
cleaned,
and all of those things. The sleep we did talk about in terms of noise. Occasionally, it does get a bit hard, especially if somebody's in a room with 4 other people.
In my next life, I'm going to come back as somebody who makes better batteries for those IV poles.
Yes.
The beeping on those things, I think, very challenging in that setting when the sleep cycle's already off and so many noises, especially in a 4-bedroom where there's IV poles beeping and lights and noise. So, but yeah, trying to diminish those things.
And if they do tolerate them, having earplugs in that setting can help out a little bit.
Okay, well, I guess one sort of final thing before we close is about how people can sort of ready themselves at some points for an emergency department visit. So the Alzheimer's Society of Canada has some good tips, and they have an older adult hospital readiness series as well. And these are checklists that might be useful for people to consider in terms of, if your loved one has been in the hospital already, you may have a better idea of what to expect. But if it's never happened before, people with dementia are at higher risk of falls or having delirium. So check out some of their suggestions about kind of having a bit of an emergency ready-to-go bag. So if you do have to go to the emergency department or your loved one is admitted to hospital suddenly, you might have a bit of an emergency kit. So there's a way that you can kind of plan ahead a little bit. So it can be a very stressful time. So I want to thank everybody for joining us today for the Delirium live event. And as you know, these are also made available on our iGeriCare.ca/events page. It usually takes us a couple of days to get the videos up, but please do fill out the survey with any comments or feedback on the session today, as well as an opportunity to vote on our next live session. We've got a good short list of ones from previous suggestions, but it would be very helpful for people to help guide our plan for our next session. We want to thank everybody. The iGeriCare team is really looking forward to that. We enjoy putting on these events and the iGeriCare platform. We would love to continue to develop further multimedia lessons and continue to do live events. It's important for us that we maintain iGeriCare as a free resource for all caregivers of people looking after those with dementia in Canada. And so we would love your support. If you could continue and consider donating to our initiative, that would be great. You can visit our website, iGeriCare.ca. There's a donate button on the top of the website. So I want to also thank our funders from the Canadian Centre for Aging and Brain Health Innovation, powered by Baycrest. We've also been really fortunate to have support from a number of other educations, the Jaris Center at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, the Alzheimer's Society Foundation of Hamilton Halton, and our Division of E-Learning Innovation team, and the McPherson Center here at McMaster for giving us this space. Our next live event is Wednesday, May 29th at 1 o'clock, and you, the voting public, will determine our topic at that time. The survey's pinned at the top. Topics that we've been toying with: consent, capacity, and power of attorney, advanced care planning, end-of-life care, stages of dementia, and many others. So please cast your votes and give us your feedback. And once again, teamwork makes the dream work. Thank you all for joining us today, and we'll see you next month.